All right, good afternoon, everyone. Thank you so much for joining our Needs and Priorities webinar, the third in our four-part series for the pre-rulemaking cycle for 2018. If we want to go, all right, my name is Kim Rollins, and I am the Measures Management Lead for CMS. Next slide. To run through a couple of housekeeping items very quickly. The meeting is moderated and all lines are muted during the presentation. We will be taking questions after each segment. There will be 3 opportunities for questions, and then for the questions, we'll make sure the lines are unmuted, and then they will be remuted at the beginning of the next segment just to cut down on noise, etc. from all of the lines. This meeting is going to be recorded and will be uploaded to the CMS website for future use and viewing, and we will make sure that we send the link to the recording in a follow-up email. Next slide. So just to run through our agenda for this call very quickly, hopefully you guys have joined at least one of our previous 2 meetings. So you've probably already heard about the Meaningful Measures Initiative and gotten an overview of the pre-rulemaking. However, just in case you weren't able to make those calls, we're going to do a very quick 5-7-minute tops overview of the Meaningful Measures Initiative along with the pre-rulemaking as a nice reminder. I will be doing that, and then after those overviews, we will have the various CMS program leads review their needs and priorities in 3 segments. The first segment being chronic and post-acute care measures, the second clinician measures, and then finally the third hospital measures. And again, after each segment, you will have an opportunity to ask questions. Next slide, please. So in the past year or so, CMS has identified and developed our 4 strategic goals that are listed here. The first one, empower patients and doctors to make decisions about their health care. Second, usher in a new era of state flexibility and local leadership. Third, support innovative approaches to improve quality, accessibility, and affordability. And finally, improve the CMS customer experience. Next slide. And these, part of the strategic goals of CMS, and hopefully what you've seen, is the launch of the Patients Over Paperwork initiative, which was first launched last year in October of 2017. And it's our commitment and our way of reducing burden for clinicians in the effort to provide a better patient experience for our beneficiaries and those that we serve, and make sure that that relationship can get back to its meaningful state. And a large part of that, of course, becomes looking at our quality measures and seeing where we can streamline our measures and make sure that we're only putting forward the most meaningful measures possible. And so part of that is the Meaningful Measures Initiative, and that's to focus everyone's efforts on the same quality areas and lend specificity which can help identify measures. And the idea is that if we are identifying the most meaningful measures, we can hopefully reduce the number of measures, therefore decreasing the burden of quality measurement and the burden of quality reporting, and through that, again, build a better and improved patient experience for everyone. And so there are several qualities listed here of the objectives of meaningful measures, just a couple to point out. Again, making sure that our measures are patient-centered, meaningful to patients, clinicians, and providers, and in that, as a part of that, making sure they're outcome-based where possible. Again, we come to burden and minimizing the level of burden for providers, identifying significant opportunities for improvement, aligning across programs and other payers, et cetera, where possible. Next slide. So as a part of the initiative, we developed a framework, and the goal there is to achieve higher quality health care and meaningful outcome with patients. We did not do this in isolation. We drew on multiple areas and bodies of work, which are listed here, including the healthcare payment plan, work from the National Quality Forum, and the IOM vital signs, core metrics, et cetera. And we got tons of feedback from our stakeholders and experts, including but not limited to the Core Quality Measures Collaborative and our sister agency, ARC. Next slide. So here's the framework. As you can see, the patient is at the center of this, where they belong, along with our 4 CMS strategic goals. Surrounding that is our kind of cross-cutting principles around measures, hoping that all of our measures embody these 6: reduce burden, eliminate disparities, track to measurable outcomes and impact, safeguard public health, achieve cost savings, and last but not least, improve access for rural communities. And around that, we have these 6 icons, which kind of align with the bolded 6 quality priorities on the right-hand side. Hopefully, these seem very familiar to you. And then underneath of these 6, we have 19 meaningful measure areas. And the idea, again, is that these 19 meaningful measure areas are going to really focus our attention, focus our priorities, so that we can all be on the same page of where we're doing our measure development and what's truly important to capture as we're working with our patients. Next slide. So I won't walk through this in great detail, but hopefully you can kind of see the progression here. We have our quality priority, which is promote effective prevention and treatment of chronic disease. Underneath of that are 5 meaningful measure areas: preventative care, management of chronic conditions, prevention, treatment, and management of mental health, prevention and treatment of opioid and substance use disorders, and finally, risk-adjusted mortality. And then to the right-hand side of that, you have a list of example measures. These aren't all of the measures in these categories by any means, but you have example measures along with their corresponding programs of the types of measures that might fit into these meaningful measure areas. Next slide. So again, that was a very quick overview, so I really suggest and recommend, if you haven't already, you look to our Meaningful Measures website in order to gain more knowledge. You can watch a video. There are just multiple resources that go more in depth in the explanation of meaningful measures. Next slide. So for a quick reminder on where we are, a quick reminder of what is the pre-rulemaking cycle and where we are in that process. Again, here are the statutory references. It's mandated by Section 3014 of ACA, and that mandates 3 major steps. One is the annual publication of the measures under consideration, or the MUC list. That has to be done by December 1st. Second step is multi-stakeholder group, which here we're using the National Quality Forum Measures Application Partnership, or the MAP, and those meetings, et cetera, happen throughout December of the year. And then by February 1st, the MAP provides recommendations and feedback to the Secretary. Next slide. Again, hopefully you've seen these, so I won't go over them in detail, but here are some basic measure requirements for all programs, and they just, they really reflect kind of industry standards like making sure we're harmonizing with, the least amount of duplicates possible, feasibility testing for ECQM, making sure that the condition or the topic has a performance, an important performance gap that's able to identify an opportunity for improvement, aligns with CMS programs, etc. Next slide, please. Measure submissions, just a couple of reminders. Measures, change requests, questions, etc. are all done through JIRA. You can set up your own JIRA account. If you have any questions about that, you can email mmssupport@battelle.org to request access, ask questions, etc. There's a user guide on the CMS pre-rulemaking website. If you haven't been there recently, please do go there and check it out. It was completely revamped. Hopefully it's a bit more user-friendly and visually appealing. And it's easier to find some of the resources and some of the deadlines and important dates, etc. So very quickly, before we start with our CMS program lead, just a couple of other things I want to mention. One of the big things that you will notice in our conversations today, and the reason why we did a quick overview of the meaningful measures priorities, the meaningful measure areas, is that we are categorizing our measures that are currently implemented by meaningful measure areas this year. So you can see the gaps and priorities, et cetera, by each program according to the meaningful measure area. So that's a noticeable difference there. For most of the programs that we will cover today, I think the only exception being missed at this point, all of those meaningful measure area classifications are located in the CMS measures inventory tool. Again, not to give you a whole list of things to check out, but that is one more thing that if you haven't seen it, I would definitely go in there. It's a web-based inventory of all CMS measures currently in programs, as well as previous measures that have been on luck lists, measures that are in our measures under development list, et cetera. And for most of the measures that we're talking about today, you can go in there and see, again, what the meaningful measure area that the individual measures have been aligned with. As you've probably noticed, we have not yet sent out the needs and priorities documents. That will be coming shortly, and again, as soon as it is finalized and made accessible, we will make sure that that gets out to everyone on the invite, so you will have that in the coming weeks. There may be a couple of small tweaks and changes based on the presentation today versus what you'll see in the document, but most of them will be very minor in nature. So, without further comment from me, I think we're going to go ahead and get started. I think we can switch to the next slide. And then one more. So first up, we have segment 1, which is our chronic and post-acute care measures. And we're going to start off with our inpatient rehabilitation facility quality reporting programs by Tara.
Thanks, Kim, and hi, everyone. This is Tara McMullen, and today I will start with the discussion on the Inpatient Rehabilitation Facility Quality Reporting Program, history and structure on behalf of the program coordinator, Christine Grove. The Inpatient Rehabilitation Facility Quality Reporting Program was established in accordance with Section 1866 of the Social Security Act and as amended by Section 3004 of the Affordable Care Act. The inpatient rehabilitation facilities, or QRP, and for IRFs that receive the IRF prospective payment system, those IRFs are required to participate in the IRF QRP. Data sources for the IRF QRP measures include Medicare fee-for-service claims, CDC NHSN data, and the Inpatient Rehabilitation Facility Patient Assessment Instrument, or IRF-PI assessment data. Beginning in fiscal year 2014, IRFs that failed to submit data are subject to 2-point 0.02 percentage point reduction of their applicable IRF payment update. Public reporting of the IRF QRP measures on the IRF Compare website began in December of 2016. In addition to the Affordable Care Act, the Improving Medicare Post-Acute Care Transformation Act of 2014, or otherwise called the IMPACT Act, amended the Social Security Act to direct the Secretary to require inpatient rehabilitation facilities, among also that of long-term care hospitals, skilled nursing facilities, and home health agencies, to report standardized patient assessment data and data on quality measures, including resource use measures. The IMPACT Act requires CMS to develop and implement quality measures to satisfy at least 5 measure domains. Those domains are functional status, cognitive function, changes in function and cognitive status, that's one domain, skin integrity and changes in skin integrity, medication reconciliation, incidence of major falls, and the transfer of health information when an individual transitions from a hospital or critical access hospital to a PAC provider or home. The IMPACT Act also requires the implementation of resource use and other measures and satisfaction of at least the following domains: total estimated Medicare spending per beneficiary, discharge acuity, and of all conditions risk-adjusted, potentially preventable hospital readmission rate measure. So for the IRF QRP, this quality reporting program currently has 17 measures that have previously been finalized. As of October 1st, 2018, the pressure ulcers new and worsening quality measure and the all-cause unplanned readmission for 30 days post-discharge measure will be sunset from the IRF QRP. Right now, as it stands with the 17 measures that have been finalized and implemented in the program, one of these measures is classified under the effective prevention and treatment meaningful measures area domain. 5 measures are classified under making care safer meaningful measure domain. 4 measures are classified under the communication and care coordination meaningful measures domain. 1 measure is classified under the best practice of healthy living meaningful measures domain. And 5 measures are classified under the patient and family engagement meaningful measures domain. And 1 measure, finally, is classified under the making care affordable domain. And you can see this on your table on the slide. CMS has identified the communication and care coordination domain as a high priority domain for future measure considerations, specifically in the priority area of transfer of health information and interoperability. Specifically under this area, the communication of health information, such as medication profiles, is critical to ensuring safe and effective transition from one health care setting to another. Medication errors, poor communication, and poor coordination between providers, along with rising incidence of preventable adverse events and hospital readmission, emphasize the importance of the timely transfer of health information and care preferences at transition. And that is the IRF QRP. And I'll now hand it over to my colleague, Lorraine Witkaiser, to tell us about the Long-Term Care Hospital Quality Reporting Program.
Thanks, Sarah. Yes, I am Lorraine Witkaiser, and I'm just going to briefly go over and discuss the Long-Term Care Hospital Quality Reporting Program, or LTAC QRP. I'm not going to read and tell you the whole background history because it's the same as the IRF. The statutory authorities for the Long-Term Care Hospital Quality Reporting Program, as well as the mandates of the IMPACT Act, apply both to the LTAC and the IRF program. So currently in the LTAC QRP program, we have 17 finalized measures. They fall into 3 categories: CDC measures, assessment-based measures, and also claims-based measures. The following table shows for them, that's up there now, details the number of quality measures in the LTAC program prioritized under the quality priorities for the Meaningful Measures Initiative and are currently implemented or proposed in the program. Noteworthy is that as of October 1st, 2018, just like the IRF, the all-cause unplanned readmission 30 days post-discharge measure will be sunset from the program, as well as the pressure ulcer new and worsening measure. This measure is being replaced with the revised pressure ulcer measure entitled Changes in Skin Integrity Post-Acute Care Pressure Ulcer Injury. As you can see on the table, the domains that are still within the LTAC QRP program: 3 measures are in the effective prevention and treatment. 6 measures fall into the making care safer domain. 3 measures are in the communication care coordination. 1 measure is in the best practice of healthy living. 1 measure falls in making care affordable. And then 3 measures are in the patient and family engagement. the high priority meaningful measure areas of the future measures under consideration also fall in communication care coordination in the measure entitled Transfer of Health Information and Interoperability. This is also the same for IRF that was just mentioned by Sarah. The communication of this health information, such as medication profiles, is critical for ensuring the safe and effective transition from one healthcare setting to another. These medication errors for communication or coordination between providers, along with the rising incidence of preventable adverse effects in hospital readmissions, emphasize the importance of this timely transfer of health information and care preference at transition measures. So we have only included one measure under consideration with the LTAC QRP in the 2019. That's it. And now I'm going to turn it over to Carol Schwartz.
Hello, my name is Carol Schwartz, and first I will be presenting on the Home Health Quality Reporting Program. The Home Health Quality Reporting Program, HHQRP, was established in accordance with Section 1895 of the Social Security Act. Home health agencies are required by the Act to submit quality data for use in evaluating quality for home health agencies. Section 1895 of the Act also requires that home health agencies that do not submit quality data to the Secretary be subject to a 2% reduction in the annual payment update effective in calendar year 2007 and every subsequent year. Data sources for the HHQRP include the Outcome and Assessment Information Set, or OASIS, and Consumer Assessment of Healthcare Providers and Systems, or CAP, and finally, Medicare Fee-for-Service Claims. As in the IRF, LTAC, and SNF quality reporting programs, the Impact Act has expanded the Home Health QRP program to report standardized assessment data and data on quality measures, including resource use measures. And now if we can go to the table. Thank you. As you can see on the table, currently home health agencies, there are 4 measures for effective prevention and treatment, 5 measures for making care safer, 9 measures for communication and care coordination, 1 measure for healthy living, 1 measure for making care affordable, and 7 measures in patient and family engagement. High priority domains for future measure consideration in the HHQRP are patient and family engagement. Care is personalized and aligned with patients' goals. Functional status and preventing functional decline are important priorities to assess for home health patients. Patients who receive care while in a home health setting may have functional limitations, individual functional goals, and may be at risk for further decline in function due to limited mobility and ambulation. Also, as with the IRF and LTAC QRP program, another priority is communication/care coordination, transfer of health information, and interoperability. The communication of health information, such as medication profiles, is critical to ensuring safe and effective transitions from one healthcare setting to another. Medication errors, poor communication, and poor coordination between providers, along with the rising incidence of preventable adverse events and hospital readmissions, emphasize the importance of the timely transfer of health information and care preferences at transition. Now I will present on the Hospice Quality Reporting Program. You can forward the slide, please. The Hospital Quality Reporting Program was established in accordance with Section 1841I of the Social Security Act and amended by Section 3004 of the Affordable Care Act. The HQRP applies to all hospices regardless of setting. Beginning in FY 2014, hospices that fail to submit quality data will be subject to a 2% point reduction to their annual payment update. Also, as of August 2017, the Hospice Compare website went live. Hospices are currently reporting on 10 measures collected through the Hospice Item Set, or the HIS, and the Consumer Assessment for Healthcare Providers and Systems, CAP. The Hospice Quality Reporting Program measures that are currently in place are on the table provided, if you could advance the slide to the table. There is one measure for communication and care coordination, and there are 9 measures in patient and family engagement. High priority areas for future measure development include effective prevention and treatment. Specifically, symptom management outcomes are a high priority for the HQRP for providers, patients, families, and other stakeholders because symptom management is a central aspect of hospice care. Another priority is communication, care coordination, and/or patient and family engagement. Patient preference for care is difficult to measure at the end of life when patients may or may not be able to state their preferences and may also have changes in their preferences. These preferences should be incorporated into any new measure development. Making care safer, specifically timeliness and responsiveness of care. While timeliness of referral to hospice is not within a hospice's control, hospice initiation of treatment once the patient has elected the benefit is under the control of the hospice. Responsiveness of the hospice during time of patient or family need is an important indicator about hospice services for consumers. And finally, communication and care coordination. Measurement of care coordination is integral to the provision of quality care and should be aligned across all care settings. I will now turn it back to Tara McMullen, who will present on the Skilled Nursing Facility Quality Reporting Program.
Thanks, Lorraine, and thanks, Carol. And Tara again, and now to discuss the Skilled Nursing Facility Quality Reporting Program. So the Improving Medicare Post-Acute Care Transformation Act of 2014, or again the IMPACT Act, added Section 1899B to the Social Security Act, establishing and mandating the implementation of the Skilled Nursing Facility Quality Reporting Program. The Skilled Nursing Facility, or skilled nursing facilities that submit data under the SNF PPS, are required to participate in the SNF QRP, excluding units that are affiliated with critical access hospitals. Data sources for the SNF QRP include Medicare fee-for-service claims and minimum data set assessment data, or MDS assessment data. Beginning in fiscal year 2018, providers that fail to submit required quality data to CMS will have their annual updates reduced by 2 percentage points, 2.0. As with the LTAC, the IRF, and the Home Health Quality Reporting Program, under the IMPACT Act, the IMPACT Act has a few requirements. It requires CMS to develop and implement quality measures to satisfy 5 measure domains, and the IMPACT Act also requires the implementation of resource use and other measures. So the SNF QRP currently has 12 finalized quality measures, as with our sister quality reporting program. As of October 2018, the quality measure, pressure ulcers, new and worsening, will be sunset from the SNF QRP. So for the SNF QRP, we currently have 3 measures that have been adopted under the meaningful measure domain of making care safer, 2 measures that have been adopted under the communication and care coordination of meaningful measure domain, 1 measure under the best practice of healthy living meaningful measure domain, 1 measure under the making care affordable meaningful measure domain, and 5 measures under the patient and family engagement meaningful measure domain, as shown on the slide. So as with the LTAC and the Home Health and the IRF Quality Reporting Programs, CMS has identified the communication and care coordination domain as a high priority domain for future measure consideration for the meaningful measures area of transfer of health information and interoperability. And as with our other quality reporting programs, medication errors and poor communication and poor coordination between providers is an issue, along with the rising incidence of preventable adverse events. So really assessing the transfer of health information in this area, the timeliness of that transfer, and care preferences at transition is critical. And thank you, and I believe that is it for post-acute care.
Yes, thank you all for presenting. That's it for our segment one. I believe that we're going to temporarily unmute the lines for a moment and see if there are any questions from our participants. And also, feel free if you want to enter it in the chat to do that as well.
Hello?
No, I can hear you.
Hello?
Yes, I can hear you.
This is Dr. Antonelli from Boston Children's Hospital. Thank you for the to see how much emphasis on prioritizing gaps, care coordination is in the discussion so far. And my question has to do is now a lot of the work of care coordination is embedded in the, I think it's called the Patient Experience and Function Committee. One of the observations that I've noted over the years that I've had the privilege of being part of the NQF is that there can be different measures of care coordination in different committees. And so coordinating the discussion of care coordination measures has been a bit problematic in the past. So can someone speak, please, to the structure of the various committees, including their nomenclature, how they relate to each other? Because I'm excited to hear about an emphasis on care coordination, but I want to make sure that we have an optimal structure and lines of communication to advance this work.
Hi, this is Sophia Chan. There isn't any specific systematic structure regarding the communication of various NQF standing committees. However, NQF strives to enhance communication across their projects to ensure efficiency and openness and transparency. In so doing, they also produce final reports of their project on a yearly basis. There was a final report on the care coordination project, I think which was published last year. I'll be happy to find the link and send it to you. NQF provide an overview of the strengths and limitations of the measure methodology and also discuss why a measure got endorsement or did not get endorsement. So I think that you might find it interesting and helpful.
So if I can follow up, please. So I am mindful of the reports that come out, but I'm just wondering, since care coordination used to be a standing committee and now it's part of patient experience and function, is the intention that gaps in care coordination measure sets will be identified inside the patient experience and function committee, and or all measures of care coordination that get submitted for consideration will specifically come to that committee? So it's actually measure curation and tracking during the process of evaluation, and then the approach to endorsement or not that I really want to be mindful about.
I think it would be helpful if we discuss further offline, but I can tell you that the standing committee would identify the priority areas and gap areas in the context of all the measures that are being submitted for a particular cycle. But as you said, these measures may be reviewed in different standing committees. So having access to the final reports will give you a broader view of the priority areas and what the gap areas would be across various topic areas. But if you're interested, I'll be happy to discuss further offline.
Okay, thank you.
Thank you.
Hi, this is Raj Mahajan, and I have two questions and kind of comment. And so the first one is, as we also, around the same time, working on gap areas in physician measures in MACRA and MIP setting, and there is a whole work that CMS has announced to fund and support and work together to develop physician measures in the areas there are gaps, and simultaneously there is a whole effort to align physician measures with facility measures. And I know within hospital setting that work is well underway, where the quality payment, the quality reporting programs can be merged, and physicians that work in a facility setting at hospital level can use hospital performance as their performance to report. And I think in post-acute, a lot of this harmonization of various levels of care is a very good concept. But if you would look at each site and the measures that have been identified to be worked upon, the physician has a very heavy involvement to make sure there is a success to that most of those measures. So why are we not being ahead of the program and making sure that the physician measures are aligned with these measures, so it's not that the facilities are reporting certain things and the physicians are out there in post-acute reporting completely different measure sets. And so since there is the opportunity with the MACRA, specialty society funding, et cetera, why are we not making sure that the physician measures are aligned with these measures that are being worked on? I think it'd be very impactful, because we always call that physician is the captain of the ship, and if they do have a program, the quality payment program that exists and that is looking for, the meaningful measures and also developing measures in gap area, I look at these measures and I say most of them are physician level measures and they should be worked upon. So that's number one. And sorry for being long-winded. Sorry, go ahead.
Yeah, hi, thanks for your question. It's a very good point. This is Tara McMullen on behalf of the Division of Chronic and Post-Acute Care, and I want to affirm that we are looking at the association between MACRA and post-acute care. We're looking at clinician activities in post-acute care, and currently CMS is just exploring ways around that continuum, ways of assessment, attribution. And so I think that's all we can speak to today, but I do want to affirm for you that we are paying attention to those nuances for the quality reporting program. Thank you.
And so I represent, no problem, and I represent AMDA, and I would, as I said, we are the only society that represent the physicians in post, especially in nursing home and skilled nursing setting, and so we would like to be at the table. We are having these discussions. We are also getting together our efforts to be possibly working on this under the MACRA funding, but we would like to at least have, and I did mention this to Kate at NQF meeting, and Kara, I think we're supposed to talk, but sorry, go ahead, whoever's speaking.
Yeah, no, thank you for your question, and that will definitely be, recorded in our minutes. As Tara said, we aren't able to speak a lot to it now, and but, it's always great to have your comments heard and like I said, recorded in the transcript, et cetera. I do want to move to a question that we received through the Q&A function of WebEx. Please feel free to submit those at any time as well. So we have someone that...
and I just wanted a real quick comment on, and again, I'm sorry not to hog the mic, but just quick comment, will be if 10 seconds, is that it's very interesting where care coordination is touted as one of the most important areas, but both at NQF and PCPI level, we have suffered a lot of almost dissolution of activities in that particular area. I just wanted to make that comment.
Thank you. I appreciate it. So just to get the question in from the WebEx Q&A, we have someone that stated, priority of transfer of information seems to be between sending hospital and SNF or ARF. Where is the measurement activity ensuring interoperability for information when the patient leaves the facility and returns to outpatient or clinic?
Yep. Hi, it's Karen McMullen. That's a very, very good question. Right now, under the care coordination domain for meaningful measures, we have in public comment 2 quality measures that assess the transfer of health information specific to the transfer of a medication profile at discharge from a post-acute care setting into other settings. Really evaluating that discharge, the sending and receiving of the medication profile between the care settings or between the providers. Within the provider quality measure, we do assess many settings of medication profile transfer and looking at routes of transfer. However, we do not have, I guess, every single setting in that care continuum within that measure. So we do ask for your feedback. It's a really good question. We do ask for your feedback on that quality measure. I can tell you that post-acute care is looking at the alignment between our post-acute care settings, and the acute care settings, and looking at the alignment of concepts such as transfer of health information. So please do go on the CMS MMS website. It's under public comments. It's an open comment, and it's called specifically the transfer of health information medication profile at discharge to the provider.
Thank you, Tara. So we are going to have to move on to our segment 2 just because we have 2 more. We have 12 more programs to get through, and I want to make sure that you're able to hear all of the other needs and priorities. So give us 1 second as we transition to that. All right, so segment 2 is our clinician measures. So first up from the Merit-Based Incentive Payment System, or MIPS, we'll have Jennifer Harris start us off.
Hello, everyone. Thank you, Kim. I'm going to provide a brief overview of the Merit-Based Incentive Payment System, or MIPS. So MIPS is just one of the pathways of participation under the Quality Payment Program, or QPP. MIPS combines 3 Medicare legacy programs: the Physician Quality Reporting System, the Value-Based Payment Modifier, or VM, and the Medicare EHR Incentive Program for eligible professionals. Under MIPS, there are 4 connected performance categories that affect a clinician's future Medicare payment. Each category is scored independently and has a specific weight indicating its contribution towards the MIPS final score. I will specifically talk about the needs and priorities for the quality category. Currently, in the quality performance category, there are 275 measures. If you could scroll down to the table, there are 123 measures in the effective prevention and treatment category. We have 26 measures in making care safer, 36 under communication and coordination of care. Currently, there are none under best practices of healthy living. We have 60 under making care affordable and 32 under person and family engagement. CMS is seeking to implement measures that meet the MIPS measure set gaps or criteria of performance. The gap areas currently include, but are not limited to, orthopedic surgery, pathology, radiology, mental health and substance use conditions, oncology, palliative care, and emergency medicine. MIPS has a priority focus on outcome measures, measures that fill a topped-out specialty area, and measures that are relevant for specialty providers. CMS has identified outcome measures as high priorities for future consideration. Outcome measures show how a healthcare service or intervention influences health status of patients. In addition to outcome measures, we also identify the following areas as high priority for 2018. Person and family engagement, communication and coordination of care, making care affordable, making care safer, and last, appropriate use. As opt-out measures are transitioned out of our program, it may lead to potential measure gaps. A measure may be considered topped out if the measure's performance is too high and unvarying that meaningful distinctions and improvement in performance can no longer be made. So topped-out process measures are those with a median performance rate of 95% or higher. We continue to identify topped-out measures through the benchmark file, which is located on our website. For 2018, we have identified 6 topped-out quality measures in our final rule. As topped-out measures are removed from the program, CMS will monitor the impact of these removals on the quality measure specialty sets that are available for clinician reporting. We strongly encourage measure developers to review the benchmark file that identifies the topped-out measures and develop measures that may replace these topped-out measures for future program years. We also welcome stakeholder suggestions and comments on these potential gaps within the measure set. For MIPS, we apply particular criteria for those measures that are submitted for potential inclusion in our program. And if you scroll down, we have a complete list of the criteria, but I'll highlight a few. Measures must be fully developed and tested with completed testing results at the clinician level and ready for implementation at the time of submission. If we scroll further down in the document, thank you. For additional details on the needs and priorities for MIPS, you can also visit the QPP website. This document and information is listed on the resource, under the resource library in the Call for Measures Quality Fact Sheet, or it will also be posted on the Pre-Rulemaking website, as Kim stated, in a few weeks. For additional questions outside of the measures, you can send those questions to the QPP help desk at qpp@cms.hhs.gov. And I'll turn it back over to Kim.
Thank you, Jennifer. Now I believe we will have Fiona Larby with the Medicare Shared Savings Program.
Thank you, Kim. Good afternoon. I'm Fiona Larby, and I will be presenting an overview of the Medicare Shared Savings Program. Section 3022 of the Affordable Care Act requires CMS to establish a shared savings program that promotes accountability for a patient population, coordinates items and services under Medicare Parts A and B, and encourages investment in infrastructure and redesigned care processes for high quality and efficient service delivery. The Medicare Shared Savings Program was designed to facilitate coordination and cooperation among providers to improve the quality of care for Medicare fee-for-service beneficiaries and reduce the rate of growth in healthcare costs. Eligible providers, hospitals, and suppliers may voluntarily participate in the Shared Savings Program by creating or participating in an accountable care organization. If ACOs meet program requirements and the ACO quality performance standard, they are eligible to share in savings if earned. There are 4 shared savings options that ACOs may participate in as part of the program. There are differences in the financial risk arrangements, however. The quality performance standard is the same across all ACO tracks in the Shared Savings Program. More information about the ACO tracks are available on our Shared Savings Program website. Currently, there are a total of 31 measures in the Shared Savings Program measure set. This includes measures reported by the ACO via the CMS web interface, claims-based outcome measures that are calculated by CMS, CAHPS for ACO survey measures, and the Quality Payment Program Advancing Care Information Data. Of the 31 measures, 13 are captured under the meaningful measure area of effective prevention and treatment. 1 of the measures is under the Making Care Safer. 8 are under the Communication and Care Coordination area, 1 under the Making Care Affordable, and the remaining 8 under the Patient and Family Engagement area. High priority quality measure areas for consideration for the future include measures addressing high priority healthcare issues such as opioid use, outcome measures that address conditions that are high cost and affect a high volume of Medicare patients, measures that are targeted to the needs and gaps in care of Medicare fee-for-service patients and their caregivers, measures that align with CMS quality reporting initiatives such as QPP, and measures that support improved individual and population health. Thanks, Kim. I'll hand it back to you now.
Thank you. So we're going to start off with a couple of questions that came in through the WebEx QA, and then after we get these two questions done, then we'll open up the lines to see if there are any further questions. So first off, if the measures must be fully developed, how are some eligible for review? I'll have the CMS team jump in here, but basically this is more of an definitely more of an exception than a rule. At times there are some measures that Congress wants to see in the MUC list and in the program sooner rather than later, and therefore we're unable, statutorily we're unable to wait until the next MUC cycle, and then they go on the MUC list when they're still in development, which is again, not the norm and is definitely much more of an exception. One of the more recent ones being the measures under the impact assessment, the Impact Act, my apologies. So yes, definitely it has happened, but definitely the exception than the rule. And I think for our next question.
This is Maria Durham. The other thing is the whole purpose of the pre-rulemaking process is to get really good impact on the measures, and what we found is that when they're not developed, there's not as much of an opportunity to really have the public weigh in on numerators, denominators, exclusions, and really, the qualities of the measures. So, it's definitely would reiterate that it's the exception, not the rule, when they're not fully developed and tested.
Thank you. We're going to go to our next question that just came in referencing previous, in referencing previous comments and questions about the lack of alignment of macro-MIPS to a SNF population. What do we anticipate the lag time until there can be clinical measures added to the macro clinical measure set?
Well, currently, I don't think, because we're in rulemaking, I don't think I can speak to any future measures being added to measure sets, but we do try to align with other programs where we can and where it is applicable. So,
and as just to also add, as Tara mentioned previously when we were answering segment 1 questions, the team that works on the SNF population and post-acute care, et cetera, are currently and actively working with the MIPS team to see what further work can be done there, and are exploring that work actively. Again, with rulemaking coming up, there's limited information that we can share at this time, but we do recognize that it's an area that we're currently working on. And to note, kind of as an add-on, and I think this remains the same, is that previous question also relates to a similar gap for older, frail elders and macro clinical measures. Okay, so I am going to have you open the lines, Martin, as we answer our next question. Answer our next question. So if you could do that, I would appreciate it. The next question that came in through the WebEx Q&A is what leads to the exemption of testing requirements for some measures? And I think if we have Shauna on the phone, I think that she was going to answer that.
So I know for Is all fully developed measures.
Just to repeat that, for MIPS especially, fully developed measures with testing information and data is a requirement. Do we have any questions?
I'm not Shauna, Kim, but I would agree with you in that there are no exemptions for testing requirements. I mean, there are times where, you know, because of statutory requirements, we need to push measures through that are not fully tested and or endorsed, but there's no way that testing requirements would ever be completely waived.
Do we have any questions from the phone? I believe the lines are unmuted.
I was going to ask you for that. Whether it's just.
I'm getting a little bit of muffling. Can the one person speak up? I can hear you a little bit. Okay, I'm not hearing anything. I think I'm just getting background noise. If you are trying to get a question through, please feel free to submit it through the Q&A. But we're getting a lot of feedback, and I don't hear anyone, so I think we're going to move on to segment 3. Thank you so much for all of your questions regarding segment 2. All right, so for segment 3, there are several more programs in this, but we split them up on 2 slides, thinking that there were a lot. So segment 3 is our hospital measures. So we are going to have Robert Morgan kick it off with hospital-acquired condition reduction program.
Thank you. This is Robert Morgan. In October 2014, CMS began reducing Medicare payments for subsection D hospitals that rank in the worst performing quartile with respect to hospital-acquired conditions. The quality measures in the HAC reduction program seek to promote quality of care by reducing the number of HACs in the hospital acute care setting. All measures adopted for the program follow the criteria established by the Deficit Reduction Act of 2005, and that they consist of high volume or high cost conditions that could be prevented by the use of evidence-based guidelines. Hospitals are scored using a total HAC score based on measures categorized into 2 domains of care, each with a different set of measures. Domain 1 focuses on patient safety. It includes the PSI-90 composite, which captures occurrences of adverse events among Medicare fee-for-service discharges. Domain 2 focuses on hospital-acquired infections and includes 5 CDC measures. All measures in the HAC reduction program address the quality priority of making care safer, with the measure in Domain 1 addressing the preventable healthcare harm meaningful measure area, and the measures in Domain 2 addressing the healthcare-associated infections meaningful measure area. Measures selected for the program further our efforts to reduce HACs and improve patients' quality of care by reducing complications and mortality, while simultaneously decreasing costs. The program has an emphasis on measures that are high cost, high volume, and reasonably preventable indicators of patient safety. These measures should fall within the preventable healthcare harm and healthcare-associated infections meaningful measure areas. And with that, I'll pass the ball to Erin Patton for HRRP.
Thank you, Robert. The Hospital Readmissions Reduction Program was established under Section 3025 of the Affordable Care Act. HRRP provides an incentive for hospitals to reduce the number of excess readmissions that occur in their setting. A readmission is defined as an admission to an acute care hospital within 30 days of discharge from the same or another acute care hospital. In FY 2018 IPPS final rule, CMS changed the methodology to calculate the payment adjustment factor in accordance with the 21st Century Cures Act to assess penalties based on a hospital's performance relative to other hospitals treating a similar proportion of Medicare patients who are also eligible for full Medicaid benefits. This will begin with the FY 2019 program. There are currently 6 measures in the HRRP program: acute myocardial infarction, heart failure, pneumonia, chronic obstructive pulmonary disease, elective total knee and total hip arthroplasty, and coronary artery bypass graft surgery. As seen in the table, all 6 measures fall under the communication and care coordination meaningful measures area. CMS identified to promote effective communication and care coordination as a high priority for future measure consideration. I'll turn it back over to Robert.
Thank you, Erin. The Hospital Inpatient Quality Reporting Program was established by the Medicare Prescription Drug Improvement and Modernization Act of 2003 and expanded by the Deficit Reduction Act of 2005. The program requires IBPS hospitals to report on a mandatory set of clinical quality measures, as well as at least 1 quarter of data for a subset of 4 electronic clinical quality measures collected from among 15 ECQMs. Performance of quality measures are publicly reported on the CMS Hospital Compare website. The hospital IQR program currently has 23 measures in the effective prevention and treatment priority, 10 measures in the making care safer priority, 11 measures in the communication care coordination priority, 11 measures in the making care affordable priority, and 3 measures in the patient and family engagement priority. The hospital IQR program ECQM measure set is aligned with the EHR incentive program for eligible hospitals and critical access hospitals, with the exception of ED3, which is only in the EHR incentive program. The hospital IQR program measures cover a variety of meaningful measure areas within these priorities, albeit with a few notable gaps. Going into this pre-rulemaking cycle, the program has identified several high-priority meaningful measure areas for future measure consideration, including patient-reported functional outcomes, care is personalized and aligned with patients' goals, seamless transfer of health information, prevention and treatment of opioid and substance abuse disorders, and preventable healthcare harm. I also note that the program will give preference to less burdensome claims-based and electronically specified clinical quality measures rather than chart-abstracted measures, while also recognizing that there may be some chart-abstracted measures addressing high-priority quality gaps which might not be able to be feasibly specified as an ECQM or claims-based measure. And with that, I'll pass it to Joel Andrus for PCHQR.
Thank you, Robert. Good afternoon. My name is Joel Andrus. I'm the measure lead for the PPS Exempt Cancer Hospital Quality Reporting Program. As you may be aware, the program was mandated by Section 3005 of the Affordable Care Act in 2010. The Secretary was required to develop a voluntary program for PCHs to submit quality data for the purpose of quality reporting, with the first year of reporting taking place in fiscal year 2014 for the initial 5 measures of the program. Since that time, the program has substantially expanded to include a variety of quality measures addressing areas including effective prevention and treatment, patient safety, care coordination, and most recently, end-of-life care. The current breakdown of measures includes 7 effective prevention and treatment measures, 7 patient safety measures divided between the healthcare-associated infections domain and the preventable healthcare harm domain, 1 communication care coordination measure for admissions and readmissions, 1 appropriate use of healthcare quality measure in the making care affordable domain, and 5 patient and family engagement measures, including 4 new end-of-life measures implemented in last year's final rule. We continue our focus in substantive areas, including care coordination, not only with hospitals, but with outpatient settings, including hospice care. We're also interested in looking at incorporating measures of functional status and the end of life, appropriate utilization of various cancer treatment modalities, including chemotherapy, and measures that focus on patient engagement, patient-centered planning, shared decision-making, and patient-centered quality of life outcomes. Our requirements for our measures remain unchanged for this program and are provided on the slide here. But in general, the measures should be fully specified with specifications being publicly available. It should be fully tested, should address an important topic with a performance gap, and should be supported by strong evidence. Finally, the measures should be feasible for implementation by CMS across the PBS exempt cancer hospitals and should result in limited unintended consequences. I'll also note that we are currently interested in quality measures that address both cancer care in general and measures that address care for specific types of cancer. And so it's possible that a measure that's applicable to one form of cancer may still be a gap in other forms of cancer and are worth considering for submission if you believe that the measure is well supported. With that, I will hand it over to Dr. Jesse Roach for the ESRD Quality Incentive Program.
Hello. More than 30 years monitoring the quality of care provided to end-stage renal disease patients by dialysis facilities has been an important component of the Medicare ESRD payment system. The end-stage renal disease quality incentive program is the most recent step in fostering improved patient outcomes by establishing incentives for dialysis facilities to meet or exceed performance standards established by CMS. ESRD QUIP is authorized by Section 1881 of the Social Security Act, which was added by Section 153 of the Medicare Improvements for Patients and Providers Act. CMS established the ESRD quality incentive program for payment year 2012, the initial year of the program in which payment reductions were applied. Section 1881 of the Act requires a secretary to establish an ESRD quality incentive program by 1, selecting measures, 2, establishing the performance standards that apply to the individual measures, 3, specifying performance period with respect to year, 4, developing a methodology for assessing the total performance of each facility based on the performance standards with respect to the measures for performance period, and 5, applying an appropriate payment reduction to facilities that do not meet or exceed the established total performance score. The current breakdown of measures in the ESRD Quality Incentive Program are 10 measures in the effective prevention and treatment domain, 2 measures in the making care safer domain, 2 measures in the communications and care coordination domain, and 2 measures in the patient and family engagement domain. High priority domains for future consideration as determined by CMS are care coordination. ESRD patients constitute a vulnerable population of patients that depend on a large quantity and variety of medications and frequent utilization of multiple providers. Dialysis facilities also play a substantial role in preparing dialysis patients for kidney transplants and coordination of dialysis-related services among transient patients as consequences for much of the ESRD population. Safety: ESRD patients are frequently immune-compromised and experience high rates of bloodstream infections, vascular access-related infections, and mortality. Additionally, some of the medications used to treat these patients may cause harmful side effects such as heart disease and bone disease. Lastly, patient and caregiver-centered experience of care. Sustaining and recovering patient quality of life was among the original goals of the Medicare ESRD Quality Incentive Program. This includes issues such as physical function, independence, and cognition. Quality of life measures should also consider the life goals of the particular patient when feasible. And with that, I'll turn it over to Robert Morgan.
Thanks, Jesse. I'll briefly touch on the HR Incentive Program before moving on to HCDP. The American Recovery and Reinvestment Act of 2009 amended the Social Security Act to authorize incentive payments to eligible hospitals and critical access hospitals that participate in the EHR Incentive Program to promote the adoption and meaningful use of certified electronic health record technology. EHs and COS are required to report ECQMs using CERT in order to qualify for incentive payments under the Medicare and Medicaid EHR Incentive Programs. As I mentioned previously, the EHR Incentive Program for eligible hospitals and critical access hospitals measure set is aligned with the Hospital IQR Program ECQM measure set, with the exception of ED3, which is only in the EHR Incentive Program. As such, any ECQM submitted for the Hospital IQR Program should also be submitted to the EHR Incentive Program. By extension, the EHR Incentive Program's high priority measure areas for future consideration are aligned with those that previously discussed the Hospital IQR Program. Moving on to HCBP, the Hospital Value-Based Purchasing Program was established by the Affordable Care Act, under which value-based incentive payments are made each fiscal year to hospitals meeting performance standards established for performance period, using the same hospital quality data reporting infrastructure developed for the Hospital IQR Program. Measures are eligible for adoption in the Hospital VBP Program based on several statutory requirements, including specification under the Hospital IQR Program, posting dates on the Hospital Compare website, and they must be quality measures other than measures of readmissions. Currently, the program includes 6 measures in the effective prevention and treatment priority, 7 measures in the making care safer priority, 4 measures in the making care affordable priority, and 1 measure in the patient and family engagement priority, with most of the program measures addressing the risk-adjusted mortality, healthcare-associated infections, and patient-focused episode of care in meaningful measure areas. Going forward, high priority areas for future measure consideration include patient-reported functional outcomes, prevention and treatment of opioid and substance use disorders, and the risk-adjusted mortality meaning for measure areas. And with that, I'll pass it to Vinita Mayor for ASCQR.
Thanks, Robert. Good afternoon. This is Vinita Mayor, and I will be presenting the three programs, which is the ASC Quality Reporting Program, the Hospital Outpatient Quality Reporting Program, and the Inpatient Psychiatric Facilities Quality Reporting Program. I'm going to start with the ASC. The ASC Quality Reporting Program was established under the authority provided by Section 109D of the Medicare Improvements and Extension Act of 2006. The statute provides the authority for requiring ASCs paid under the ASC fee schedule to report on process, structure, outcomes, patient experience of care, efficiency, and cost of care measures. ASCs receive a 2 percentage point payment penalty to their annual payment updates for not meeting program requirements. CMS implemented this program beginning with the calendar year 2014 payment update. The table on the following page lists the quality measures prioritized under the quality, the different meaningful measure areas currently implemented in the program as finalized in the calendar year 2018 OPPS and prior rules. The measures fall under all of the meaningful measure areas. There's 2 under the effective prevention and treatment, 5 under making care safer, 5 under communications and care coordination, 1 under making care affordable, and 2 under patient and family engagement. Given the parsimonious measure set currently in use in the program, CMS has identified all of the following meaningful measure areas as high priority areas for future measure consideration. We do have some measure requirements. I'm not going to read through the entire list, but would like to highlight that the measures must adhere to CMS statutory requirements. Measure must address an important condition topic for which there is analytical evidence that a performance gap exists and that measure implementation can lead to improvement in desired outcomes or cost utilization. The measure must be field tested for the ASC clinical setting. Moving on to the Hospital Outpatient Quality Reporting Program. The Hospital Outpatient Quality Reporting Program was established by Section 109 of the Tax Relief and Healthcare Act of 2006. The program requires subsection D hospitals providing outpatient services paid under the OPPS to report on process, structure, outcomes, efficiency, cost of care, and patient experience of care. Hospitals receive a 2 percentage point reduction of their annual payments under the OPPS for non-participation in the program. Performance and quality measures is publicly reported on the CMS Hospital Compare website. The table on the following page lists the quality measures currently implemented in the program as finalized in the calendar year 2018 OPPS and prior rules. The measures fall under most of the meaningful measure areas. There's 2 under effective prevention and treatment, 3 under making care safer, 9 under the communications and care coordination area, 7 under making care affordable, and 2 under patient and family engagement. Again, given the parsimonious measures that currently in use in the HOQR program, CMS has identified all of the following meaningful measure areas as a high priority area for future measure consideration. We do have measure requirements, and I'm going to highlight a few. The first one being that the measure must adhere to CMS statutory requirements. Measure must be fully developed, tested, and validated in the hospital outpatient setting. And feasibility of implementation is also an important criteria for the measure requirement. Moving on to the Inpatient Psychiatric Facility Quality Reporting Program. The IPS Quality Reporting Program was established by Section 1886 S4 of the Social Security Act and added by Section 3401 and 10322 of the Patient Protection and Affordable Care Act. Under current regulations, the program requires participating inpatient psychiatric facilities to report on 18 quality measures or face a 2 percentage point reduction to their annual payment update. Reporting on these measures apply to payment determinations for fiscal year 2018 and beyond. The table on the following page reflects the priorities of the IPF quality reporting program that are currently implemented in the program as finalized in the fiscal year 2018 IPPS and prior rules. So we have 10 measures under the effective prevention and treatment measure area, 2 under making care safer, 5 under communication care coordination, and 1 under patient and family engagement. The high priority meaningful measure areas for future measure consideration are, we've identified 2 of those. The first one is strengthen person and family engagement as partners in their care. The second one being make care safer by reducing harm caused in the delivery of care. We do have measure requirements, and just going to highlight a few. Measure must adhere to CMS statutory requirements. The measure should address an aspect of care affecting a significant proportion of IPF patients. The measure must be fully developed, tested, and validated in the acute inpatient setting. I'm going to turn it back to Joel.
Thank you, Vinita. Good afternoon again, everyone. My name is still Joel Andrus. The Skilled Nursing Facility Value-Based Purchasing Program was established in the Protecting Access to Medicare Act 2014, is actually known here as PAMA. The program adjusts federal per diem rate by 2% and provides an incentive payment applied based upon facilities' performance on a single readmission measure. At present, that measure is an all-cause readmission measure. However, there is a provision within the program to replace it with a potentially preventable readmission measure at a future date. That has not yet occurred. The statute provides us with no authority to implement any additional measures at this time, and so we are not currently accepting requests for additional measures to be incorporated on the measures under consideration list for this program. Though if that authority changes in the future, then we will certainly be considering measures along with the others. Thank you. That's all for SNP VP.
Thank you. Those are all the programs that we outlined in segment 3, our hospital measures. We did have a couple of questions come in. First, when and where will slides be posted? So we will have the slides for this presentation as well as our other mock presentations online on our pre-rulemaking website by the end of the week. However, it will take us a little bit longer to get the recording of those presentations on the website. But we can definitely provide the slides there by the end of the week. As I mentioned earlier, the needs and priorities documents for 2018 will be on the pre-rulemaking website later this month. Another question, or I think it was a little bit more of a comment, perhaps, that came through chat was, sorry, one second. This was earlier, and I believe in segment 2, I apologize, I must have missed it. Since this is a post-acute care group, for MIPS as well as MSSP, have we tried to break down what measures have valid post-acute populations in the denominator? For an example, only 50 or so MIPS measures of the 275 are applicable to the SNF population. And again, I wanted to read your comments. I think we addressed it at least in brief earlier, just in the fact that we are currently working on that alignment. and working on that effort to better coordinate and identify the overlap as well as the gaps between those two, between that program and population, but we cannot comment much further at this time. I think, 1 second before we open up the line, I think we have a couple of more. Yes, Martin, if you could, we would happily display the slide showing the second page of the ASC QR program again so that you can have a look. Again, it'll be on our website shortly. And we'll scroll through the second and third page of that slowly for you. At this time, I do not see any other questions through the web chat. So again, we'll open the lines briefly. If you can just make sure that if you're not actively speaking, your phones are on mute, we would greatly appreciate it. If you're having trouble getting through on the line when we unmute the line, please again feel free to submit through a chat question. That's perhaps easiest. And we will try our best to display the HAC RP again. However, I think after that one we may have to stop just because we can't scroll through the whole document. But we'll at least display these two programs again briefly. So Martin, if you could open the lines and we'll see if there are any questions. Okay, I don't hear any questions, so we'll go ahead and change really quickly to the HAC RP slide, Martin, just so we can display that briefly for folks. And then, yeah, if you have any questions, we'll give it another 20 seconds or so in the chat box to see if we have any final thoughts or questions before concluding. All right. Martin, if you could go back to the slide presentation. We just want to go over a couple of quick next steps and some information. So we have our fourth and final meeting as a part of our April series to kick off the pre-rulemaking cycle for 2018. So our fourth webinar is this Thursday, April 12th from 1 to 2 p.m., where we will have our second open forum. It's the same as the last week, but again, it's always good to have a second presentation of JIRA and, ask any questions as you become more familiar with it. Basically, we do a very quick overview of the Meaningful Measures Initiative as well as pre-rulemaking. Then we do a 15-minute or so overview of JIRA and how to work through, or how to do that workflow, and then we take questions. In August, around August 2nd, we will have our federal stakeholder-only meeting, which is a meeting for our federal stakeholders throughout HHS to comment on the MUC list before it goes into clearance. And then, of course, as I talked about earlier in the overview, the MUC list is published by December 1st. Again, I really encourage you to visit the pre-rulemaking website for resources regarding everything with the MUC list and pre-rulemaking. A lot of great last year's resources, last year's needs and priorities documents et cetera, there for you to review, and you can, of course, always ask questions. And then finally, on the last slide, there's some contact information if you have questions and need to follow up. So I haven't received any more questions through WebEx. So with that, I thank you all so very much for joining. We hope you can join us on Thursday, and we look forward to seeing your questions and measures in JIRA. Thank you.